think we can just go ahead and start with poster then 10.1, which is designing feedback visualizations from multiple data points with target users of digital binge eating and weight management intervention.
That's me. That's a mouthful. Thank you for saying that. I
No
appreciate it.
worries.
All right, let me get started. I'll share my screen.
Thanks.
Okay, so here is my poster. I'm going to try really hard to stick to the 2 to 3 minute time limit out of respect for everyone's time. My name is Adrian. I'm a postdoctoral fellow in digital mental health at CBITS at Northwestern, and I'll be talking about how we design feedback visualizations for this digital binge eating intervention. So the background for this project stems from this idea that digital interventions collect a lot of data from their users. And users often report wanting to be able to see and engage and interact with the data that they're inputting interventions, but there's no clear guidance on how to provide or visualize data back to users, especially for really complex data. And so what we did is we conducted co-design sessions with end users of this digital binge eating intervention called Food Steps, which addresses both binge eating and weight, to better understand how users would want to visualize or interact with data from multiple outcomes, in this case, their binge eating episodes and their weight, as well as how they wanted to see their progress over time. And so I'll briefly show some prototypes that we showed our users. I'm going to zoom in here so we can get a better look. And so here on the left, we had different ways of showing users how they could see their feedback on how much they're binge eating and how much their weight changed over the course of a week. And so we presented this feedback numerically, sort of just showing like, hey, your binges, you went down 3 binge eating episodes, or your weight went up 1. So just numerically, we also visualized their progress via arrows, and sort of to show like to represent the amount of change that they had. And some of these prototypes, we compared their progress towards their goals, and in other prototypes, we did not. And so we asked users about their preferences for each one, their likes and dislikes, to better understand what their thoughts were about these different prototypes to get at our research question. On the right here, we have different ways of showing how we visualize their progress over time. So we presented their longitudinal data numerically in a table, as a line graph, and then also in more of like a pictograph form represented by icons. And we asked users again about their likes and dislikes. I'll just sort of scroll down. We analyzed their qualitative data through thematic analysis. And what we learned was that users were really interested in seeing their data over time and also their data for multiple outcomes. So it's consistent with the previous literature that people want to see their data. However, they found it really overwhelming and said that like showing this level of complexity might be best to wait to do that until later on in the intervention when users were more familiarized with the intervention protocol. They noted that they really liked numeric feedback over visual representation. So the things like arrows, line graphs, icons, they really hated and just wanted data presented back in numbers. They found it was the easiest and quickest to understand. But they also found that showing this data could be really discouraging if they didn't meet their goals, or, for example, if they had low progress over time. And so there's this implication about showing this data honestly and representing it accurately, but also presenting it encouragingly in a way that supports their behavior change. Obviously, this was just design, and so some of this has to be replicated and validated in practice. I'll stop there out of respect for everyone's time. There is a QR code that you can scan here at the bottom. My poster is also on the OSF page for the conference. Here's my email as well, and I just want to acknowledge I have no conflicts of interest and that this work was supported by grants from the NIH. Thanks.
Thanks so much. Any questions? Okay, I think the next poster in the session is a pilot open trial of a text message safety behavior facing intervention for appearance concerns among women. We have either Tapan Patel or Jesse Kugel here. Okay, if not, we can move to 10.3 then, which is ACT Enhanced Peer Support Coaching for Online ACT Self-Help, Feasibility and Acceptability with College Students. which I think is you, Corey.
Yep, that's me. Can you see it all right?
If you can make it a little bigger, maybe, or go into, I don't know if the present mode will get off. Oh, no,
Um,
then we see your mode. No, it's good. It's fine.
it's fine. Okay, are you
Yeah,
sure?
it's good.
Okay. All right, cool. Well, we all know that online self-help interventions kind of struggle with adherence rates. And so while online self-help programs might be a good way for colleges to meet the mental health needs of, their large student body, the effects of these kind of interventions are stunted by poor adherence rates. And so coaching is often the most frequently used strategy for encouraging adherence and engagement. However, it's usually therapists or graduate students who are delivering the coaching, doing those kind of like weekly contacts to talk about the program, provide some accountability. And so this is often not scalable because it can be expensive to hire graduate students and therapists. So peer coaching, in which one college student is coaching another college student through the program, is one alternative model that we wanted to explore as a potentially scalable way for colleges to use digital programs to bolster the mental health of their student body. We previously tested this peer coaching model where, we have recruited students from the student body who want to volunteer to be coaches, and we give them training on how to do that coaching following a very structured protocol. And we already saw in a randomized control trial we previously conducted that this was pretty efficacious for improving adherence to the program. And so this present study looked more closely at the feasibility and acceptability of this service. We found that the peer coaching model was highly feasible, as student volunteers were pretty easy to recruit. So a lot of students were interested in getting this opportunity to coach other students. And students were also able to deliver the coaching with appropriate fidelity. So 80% of the calls and texts reached fidelity criteria. However, we did see that adherence to the coaching itself was relatively poor. Around half of the phone group adhered to the coaching, and then 36, or around like a third of the text group adhered to the coaching, which, depending on how you look at it, could be good or bad. But when you're reaching around, half of your sample and half are actually engaging with the intervention, that's actually pretty good. We did see that, however, that participants in the phone condition were significantly more satisfied with the coaching, so that format performed much better. Students in the text group were more likely to report that they would have preferred to not have a coach. You can see like almost the majority kind of in the text group or preferred to not have a coach, while the minority of the phone group preferred to not have a coach. And then we also saw that the phone coach students the text coach students also would have often reported that they would have preferred a mental health professional as opposed to another student coaching them. While in the phone group, we didn't experience that much of a preference. Students were generally in the phone group okay with having a student as a peer, or like a peer as their coach, or even preferred this over a mental health professional. We did also see that students in the phone group experienced a boost to their satisfaction with the self-help program in general. So not even just with the coaching, but with the online program they were using called Act Guide, while this boost was not experienced by the text group. We also saw that Alliance, while coaching Alliance was relatively the same around the start of coaching. So within the first 1 or 2 sessions, the phone and text group performed similarly. By the end of the program, the post-alliance was significantly greater for the phone group. This isn't to necessarily say that the phone format is always better for all college students, but works better for the majority. We saw in interviews that while many students liked the phone coaching because it was more personal and appeared to foster more alliance, some students found this less flexible format compared to texting to be difficult to find time for. Overall, this study kind of demonstrates that there will never be a fix-all kind of blanket solution for adherence to online programs, and that accounting for user preference in terms of what strategies to use to engage the user and improve adherence. This kind of personalization might be beneficial. However, on a more general level, peer support coaching seems to be acceptable intervention to students, with phone coaching typically being more well received than text messages. And I'll stop there and accept any questions. Sorry, I didn't mean to stop sharing.
I have a question, Corey. Could you talk a little bit about the training that was provided to the coaches?
Yeah, so the training period was, we actually, given we had different cohorts of volunteers, we tried a couple different training kind of periods. And so some of the volunteers were trained over a 3-week period. Others were trained over a 4 to 6 month kind of period, or sorry, 4 to 6 week kind of period. And so the training involved going through the program and then also practicing their coaching with the other volunteers who were in their cohort as they were going through the program, at just at a more accelerated rate than a participant would be going through it. And then there were also some didactic sessions on how exactly to deliver the coaching in terms of discussing the protocol, very in-depth, doing some practice sessions in the training itself when we had those didactic training sessions, and then giving that direct feedback on here's what you could have improved, or here's kind of, you did really well in this area. And then there were weekly supervision meetings to continue that learning and fidelity to the protocol. So in weekly supervision, typically coaches, we would play a recording from one of their sessions that week, and then coaches were all kind of weigh in on their feedback to kind of model what good coaching looks like.
That was great, Corey. Thanks very much. So I'm back to hosting. Thank you, Steven, for taking over while I tried to figure that out. Looks like everything is sorted out. So our next talk is development of a mobile app for caregivers of patients undergoing hematopoietic stem cell transplant. So please take it away.
Hi, yes, 1 second. I'm going to share my screen. All right. Hi, everyone. My name is Madison Freese. I'm a clinical research coordinator at Massachusetts General Hospital in the Cancer Outcomes Research and Education Program. And I'm really excited for this opportunity to speak today, and I will be speaking on the development of a mobile application for caregivers of patients undergoing stem cell transplantation. So for some background, HCT caregivers often experience considerable burden and psychological distress that often leads to a decline in their quality of life. But despite this, the psychological needs of caregivers are often unmet due to limited availability of mental health clinicians and resources. And so digital health interventions really offer an innovative way to improve the quality of life for these caregivers and reduce their burden throughout the entirety of the transplant process. And so we developed a mobile app using a 5-step process that resulted in an interface that is overall designed to provide caregivers with an interactive education and a psychological resource throughout the transplant process. And the app includes many features, as seen on the right side of the screen, including an interactive journey, educational resources, evidence-based psychological content that is CBT-based, personalization depending on the caregivers and the things they're experiencing, and then communication, exercises, some gamification to promote emotional well-being in caregivers, and then mindfulness exercises. And currently we are conducting a randomized controlled trial of this BMT Care app versus usual care in order to determine the efficacy of the BMT Care app for improving quality of life, caregiver burden, and overall mood in HCT caregivers. And at this time, I would be happy to take any questions as time allows. Thank you.
Yeah, I think if there's no questions, we can move on for now, and maybe we can circle back later at the end. Thank you very much, Madison. That was great. So our next talk is empowering mental well-being, the role of user involvement in shaping therapeutic mobile application features and mental health outcomes.
Hello, that's me. I am Juby, and I'm speaking for our group. So that's why my name is different. Let me go ahead and share. Whoop. My screen, where'd it go? Oh, my screen share isn't on. 1 second.
Let me try to figure it out.
Oh, here we go. Yay. Yeah. Perfect. Okay, let me see if I can. Where's the thing? Down here. Ooh, there we go. Okay. So I'm presenting an ongoing project focusing on a co-design of a mental health app, leveraging user involvement to enhance its effectiveness. Currently, there's like so many, tens of thousands of mental health apps available, but many lack scientific validation, which like leads to poor user engagement and adherence. Our project aims to address this gap by incorporating participatory design techniques, because research shows that apps designed with active stakeholder involvement not only succeed more, but also see higher adherence rates. So our study uses content analysis to understand how co-design can lead to user-centered digital mental health solutions. And we hypothesize that active user participation will enhance the app's relevance and utility, resulting in more effective therapeutic outcomes. For our methods, we recruited 20 participants from a larger study on family dynamics using the Colleaga app, an app that was created in our lab. And participants included parents of children aged 6 to 9, proficient in English or Spanish, from underrepresented racial ethnic groups with a child at risk for mental health issues. Over 2 months, participants engaged in 3 semi-structured interviews about their app experiences. These interviews are currently being transcribed and analyzed using MaxQDA. The process involves coding for themes like therapeutic feature enhancements, user-driven improvements, and overall satisfaction. This content analysis, along with ensuring interrelater reliability, is time-consuming and ongoing. While the study is still in progress, preliminary findings suggest several interesting insights. First, users emphasize the need for personalization features such as customizable layouts and color. Secondly, parents express a desire for the app to contextualize their child's experiences, mentioning specific anxieties or social challenges. And last, the users recommended a goal setting features to track progress and daily interactions with their children. So for future directions, to streamline the content analysis and coding process, we are exploring the use of ChatGPT as a second coder. This approach could potentially reduce the time required for inter-rater reliability and hopefully enhance the efficiency of our content analysis. By actively involving users in the co-design process and leveraging innovative tools like ChatGPT, we aim to develop a mental health app that truly meets their needs and enhances therapeutic outcomes. So yeah, thanks so much. And I'm ready for questions if anyone has any.
I have a question or two. I had one question, and then you said something about ChatGPT. I don't know. Have you tried any of the coding with ChatGPT before?
Yeah, it's not very reliable yet. What we've been doing is we've been working together as a team to code, and then so we're not only deliberating like our own inter-rater reliability, but then we're including like what ChatGPT is like coming up with. And so we're kind of using that to like go back into our code book and try to rewrite the code book to be more like concise and clear over what we're looking for. Because unfortunately, you know, the code book is written by people, and so computers don't really think like people, or programs don't think like people, you know, they think like the people that like create them. So we're hoping with like really honing in on some of like the bigger themes for our code book, we can start to get a little bit more inter-rater reliability between us and ChatGPT. But so far it's like, it's a pretty low percentage reliability, so.
Yeah, I didn't check for reliability, reliability, but I was using Atlas, and I gave it a try for their AI coding, and it wasn't very good.
Yeah.
At least not yet. Do I have time for another question, or should I go?
Sure.
Okay, my other question is that you mentioned something that some participants they would like to see the progress and
Yeah.
their therapy. Did they talk more specifically about how they would like to see it? Because in some of my past research, people also mentioned that, but all of them said, I have no idea how to see the progress, but I would like to see the progress.
No, that's yeah, absolutely. And that's a great question. What has been coming up in our interviews is that people are kind of talking about they want a place, or at least for like, especially with like monitoring their child's progress. They want a place where they can take notes whenever the child says things like, I'm feeling anxious about this. Or like, you know, because part of like our survey check-ins is we check in on like, how are you feeling right now in this moment? But then that's it. You know, we don't really like, the app doesn't tell you to go further into it. And so parents are requesting a place to maybe jot down some notes like, oh, they're feeling anxious about this. So that's one way they could potentially track progress. The other one was the last one, I think is more specific to your question. And that's like tracking personal progress, right? And so I think what they're looking for is a way to input, you know, I want to work on this specifically, and like have the app feedback, you know, ways to track that daily, right? And right now, our app is really just in the data collection part of the process, the exploratory part. And so yeah, the feedback they're giving us totally makes sense, but we haven't gotten to the part where we figure out like how to make that tracking happen, if that makes sense. Those are great questions, by the way. Thank you.
Great, thanks so much.
Awesome, thanks.
Our next talk is establishment of a digital therapeutic alliance in patients living with negative symptoms of schizophrenia.
Hi there, that's me. Let me know if you can see my poster.
It looks good.
Okay, perfect. Is it far away? Are you able to see the lettering?
No, it's definitely too zoomed out, but it's kind of a huge
Okay,
poster.
yeah. As I go through the different sessions, I will focus in on the different areas. So let me start off with the moving it over. Is that a little bit better?
Maybe a little bit more zoom. That's
Might
definitely
be a
good.
little too much zoom. Okay.
That's good.
Okay, perfect. So good afternoon, all. My name is Laura Angano, and I'm an Associate Director, Medical Science Liaison at Boehringer Ingelheim. Therefore, I'm an employee of Boehringer Ingelheim. Today, I'm going to be providing an overview of my colleagues' work on the following poster entitled Establishment of a Digital Therapeutic Alliance in Participants Living with Negative Symptoms of Schizophrenia. So for a little bit of background, currently evidence demonstrates that the quality of the therapeutic alliance between a patient and a therapist is a strong predictor of clinical outcomes. Therefore, an analogous digital working alliance between a patient and digital therapeutic may be important for engagement and outcomes. However, this is a nascent topic in digital mental health. Our specific digital therapeutic, CT155, which we are investigating here, is a prescription digital therapeutic that's being developed to treat the experiential negative symptoms of schizophrenia alongside standard of care. Experiential negative symptoms refers to symptoms such as avolition, anhedonia, asociality. So these are patients that are experiencing a lack of pleasure, a lack of motivation, and decreased social interactions. So in this specific work, we sought to determine whether patients would report establishing a digital working alliance and whether the strength of that digital working alliance varied by the severity of the symptoms or participant demographics. And we looked at this in two independent exploratory studies in patients with experiential negative symptoms. So our methods were that we measured the strength of the digital working alliance using the mobile Agnew relationship measure at week 1 in study 1 and at week 3 in studies 1 and 2. So on this scale, a score of 5 or more represents a positive alliance. And then we measured the severity of the symptoms using the Kane's MAP and MAP SR scales. And these are specific scales which were actually created specifically for measuring experiential negative symptoms associated with schizophrenia. And I'm going to zoom back out a little bit. So our key findings were that, let me try to see if that's a little bit better. So our key findings were that overall people with schizophrenia and experiential negative symptoms formed and maintained a positive digital working alliance with CT155 beta in the 2 different studies. The strength of the digital working alliance established was consistent regardless of the severity of the symptoms, the patient's age, or race. And our overall conclusion is that the successful establishment of a digital working alliance between participants with experiential negative symptoms of schizophrenia and CT155 were regardless of severity, age, or race, and this supports the further evaluation of the potential importance of the digital working alliance to clinical outcomes in participants using digital therapeutics as a treatment. And that is all. I'm happy to take any questions.
I have a quick one. Could you tell me a little bit more about CT155?
Yeah, so it's essentially it's an app that'll be available on an individual's phone, and this app delivers cognitive and neurobehavioral mechanisms via an engagement flow platform. So think of taking psychotherapy, face-to-face psychotherapy, and delivering it via an app. This app will deliver stepwise activities that are aimed at emotions and behaviors that are normally affected by negative symptoms associated with schizophrenia. So in the first study, what we did is we looked at the beta version of it. So it was essentially not an active phase, what you would call in a pharmacotherapy trial as active drug. It was a beta. So in study 1, we were just looking to determine whether the individuals can interact, they form an alliance, they engage with it daily, etc. Very introductory phase. Study 2, we had a beta phase and a little bit more of an active phase. We had the first couple of weeks where it was just really, do they establish an alliance, etc. And then in the last couple of weeks, they actually were given like goals, activities, etc.
That's great. Thanks very much, Laura.
No problem. I will stop sharing.
And now we have our last talk, which is exploring gender and sexual identity-based differences in baseline characteristics for OCD patients in a randomized controlled trial of digital mental health interventions.
Hi, thank you for the presentation. Can everyone see my poster well?
It says loading right now. Maybe let's just give it a second.
Okay.
This did happen once before, though, and it didn't really load. What was the solution that we found to that? It was like showing a PDF of it or something like that. Does anyone recall when we had that issue before?
I can just try to share the PDF version in that case.
Oh, okay,
That's
okay.
better.
Thanks. Yeah, that looks great.
Okay, perfect. Sorry about that. I'm Simai. I'm a clinical research coordinator at MGH, Center for OCD and Related Disorders. And my poster is actually a secondary data analysis of one of our large randomized control trials. So as an OCD clinic, our focus is looking at obsessive compulsive disorder, as it is a severe chronic and undertreated disorder, and specifically individuals belonging to a minority group may have a higher risk for OCD. So therefore, understanding the differences in OCD presentation in these minority groups could lead to a better outcome. So as I mentioned before, this is a secondary data analysis of a project that we had where we had US-based adults with primary OCD randomized into either an app-based condition that delivers cognitive behavioral therapy and exposure therapy for OCD, or an online health and well-being program. So I looked at the baseline measures for all of our 120 participants with primary OCD, and we conducted independent samples, t-tests, chi-square, and Fisher-Exact tests to examine the differences between gender and sexual orientation identities compared to compared to heterosexual individuals. So as you can see from our results, we did not see any significant baseline differences between gender groups. However, we did find some differences looking at the sexual minority groups, such as the sexual minority group being significantly younger, having lower quality of life, and reporting more religious obsessions and checking compulsions compared to the heterosexual group. There were some notable trend level differences and other obsessions and compulsions along with alcohol use, but not significant enough for us to report. So as we can see here that the impact of minority status on OCD symptom presentation is an important topic that we should look at. And minority groups may have additional stressors that may impact presentation of obsessions and compulsions along with comorbidity with other disorders as well as quality of life. Our results suggest that patients seeking digital treatment for OCD at least are largely similar across genders with some important differences in clinical presentation based on sexual minority status. So clinicians should be aware of a higher likelihood of religious obsessions and checking compulsions in their assessments and case conceptualizations. However, of course, we had some limitations, primarily that we had low diversity percentages in our samples. So future research with more diverse samples is definitely needed to have stronger effects and solutions. So thank you so much for listening, and I'm happy to take any questions.
I have one. Did the members of the sexual minority have just like overall higher scores on OCD?
No,
Measure?
that was
No?
definitely a part of my hypotheses that I assumed that the Y box score, therefore like OCD severity would be maybe higher in the sexual minority group. However, we did not see a significant difference just based off of the Y box scores. But again, it could be helpful to have a larger sample size with more individuals belonging to the minority group to see if there is a effect in the Y box, but not in our sample.
Gotcha. Yeah. How many people were in the sexual minority group in your sample?
So it was 25% of our sample. So we were like doing 25% comparing to the 75%. Therefore, definitely that is not the best comparison to have, but that's what we had.
Could have been worse. Thank you.
Yeah, of course. I'll stop sharing. Thank you.
Any other questions? Okay, so we still have 10 minutes. Dr. Schuler just posted in the chat a few minutes ago this OSF page that has all of the posters, which is great. So you can follow up with the presenters and give a closer look. Some of those posters had a lot of information, so you can give it a good read. So I think with this next 10 minutes, if there are any lingering questions for the speakers, you can just shout them out and we can discuss that way. You can put them in chat, or you can look over their posters again via the OSF. So I'll just say thanks in case some of you dip out early. Thanks to all the presenters. They're really great talks. I learned a lot. I appreciate it.
I'd be curious for the empowering mental well-being poster and the conversations around ChatGPT, if there's any just lessons learned you have so far in terms of things you would do differently already or things that you've changed I mentioned in the chat, we've been trying to do some chat GPT coding, one of our projects, and similarly have like tried to be thinking about what's the right mixture between human coding or human creation of these code books and chat GPT stuff. But yeah, just curious if you have any lessons learned.
So far, I feel like lessons is hard because like we are working on this as a team. And so I'm not the one directly working with ChatGPT, but I know that like the way we've been going about it is just as we deliberate and talk as a group, one thing that I like to bring up often is like when we're working with these programs like ChatGPT, just because it's not working right now doesn't mean that it can't work kind of thing. And we're already doing so much work like between ourselves with the interrelator reliability stuff. And so I feel like the key is just trying to, as ChatGPT gets more info and gets more beefed up, it learns more like constantly. So every time we're using it, it's picking up stuff and it's learning more. And so I think like so far we've only really done one round with ChatGPT where we've been able to like compare like the inter-rater reliability between like the people and the machine, right? And so yeah, so our approach is just simply trying to speak in ChatGPT's language. Like it likes being fed prompts in a very certain way. And I feel like the biggest one from what we've seen and discussed with research is like whenever you're feeding it prompts to try to start like with your largest concept and then whittle down, just like how we write papers, right? And it seems to like that.
Cool.
But
Awesome.
that's as far as, oh, I'm sorry, go ahead.
No, I was just saying that thanks. It's really helpful.
Yeah, that's as far as we've gotten. And hopefully as we continue to whittle and work with our code book, because I feel like that's where like the miscommunication is happening. And so instead of just trying to feed it like our whole code book, we're trying to like do like maybe we should try it one bit at a time, like one code at a time, and then trying to break that down to where it's like, can we start to get more reliability and teach it like this is how we like to use our code book. So it's kind of like it feels very much like the smartest yet dumbest like research assistant you could ever work with, but it's always there.
Yeah, we've done some work with ours where we've tried to do some like very first level coding where we just put things into some like different categories and then use ChatGPT to create some codes within those categories. But yeah, no, it's been really interesting to try to think about it because as you mentioned, like if it could work, it'd be great, right? Like you just put your data in and get it coded. But yeah, it's interesting.
It is, and there is like I don't know if it's control. It might be a bit of like human control. Like there's a part of me that really enjoys like the transcription and coding process too, like as a human being and like figuring that stuff out. So I don't know, who knows like what's better, but yeah, I guess the numbers will tell us.
I have a quick question for you, Stephen. Are you using the paid version or the free version, and how?
Yeah, we use the paid version. We feed it in the back end, so we do a lot. Yeah, we're not using the free version for it.
Yeah, we've tested out both, and there's definitely limitations to the free one.
Oh yeah.
Yep.
And so it's just like a constant black box, and the iterations keep changing as they keep sending out new builds.
Yeah.
It's been interesting. Thanks for sharing.
Yeah, thank you.
I have a question for Adrian. So he's there. Okay, so my background is in design, not psychology, but I find so I've been interested now in progress. So that was part of my question to Jacqueline and for the other paper. And I find it interesting that people prefer numerical results, but at the same time, the things that were presented was like amount of binge eating or weight, and those are numerical things. I'm curious if there was any discussion about, or if there's any sort of measurement that goes around how people feel and emotions, and if there was any discussion about how to track progress around that.
Yeah, totally. And maybe numeric wasn't the totally right choice of word. But when compared to like arrows or other visual representations that wasn't so like numeric, like it had no numbers attached to it, people found it very like confusing or hard to understand. So when we were just showing like, hey, what do you think of this prototype for seeing your progress at the end of the week and seeing how you did, they just took a longer time to understand it and were quite frustrated with just the process of having to like really understand what it meant versus just a quick feedback mark that said like, hey, your binge has changed by X, or like this went up by Y. And so it was just easier for them to understand and preferred those versions more. They did talk a lot about how it would make them feel. So in fact, like in terms of how they did compared to their prediction or what their goal was, they talked about their emotions in terms of like, oh, this would make me feel, you know, really demoralized if I didn't meet my goal, and this is the feedback that I'm getting, or actually I would feel worse if I know that my weight went up as compared to like if my binges went up or there was no change there. And so a lot of the conversation was really centered around emotions. And we're writing up this paper right now, and there's a really big like section on like just sort of thinking about like the population and the end user specifically, and how the results relate to that. So thinking about this population with binge eating and obesity, a lot of them talked about how there's a lot of shame that comes with their specific concerns, and that they did not want an intervention that would like contribute to that further shame, and that that specific like preference or consideration was one of their biggest motivations as to why they preferred the different prototypes.
Is there any more questions for speakers? We have a couple more minutes. Okay, well, let me thank all the speakers one more time. Thank you all, everybody that came to participate and ask questions. It was a great session. So everyone be well. I'll see you around the conference.